So we begin with NHS Cervical Screening Program, NHS CSP, colposcopic diagnosis, treatment and follow-up. Okay. So colposcopic diagnosis, treatment and follow-up. So when the patient comes for colposcopy, what is the data which is recorded at the colposcopy? Okay. So which parameters we will see and what is to be documented? So what is the indication for referral? When the patient comes for colposcopy, that means there is a problem with her HRHPV and the cytology. So whether it is cytology or HPV, what is the reason that needs to be documented? Then HRHPV and cytology grade. What is the grade of cytology and the status of HRHPV? That must be documented. Is there a cervix that or post hysterectomy or surgical case that needs to be mentioned? And then adequacy of the examination. Then during colposcopy, whether entire cervix and squamocolonial junction is visible or not, that needs to be documented. Is there any vaginal or endocervical extension? That is to be noted. Then lesion features. What is the exact colposcopic appearance, your colposcopic finding, that will be documented. Impression of the lesion, whether it is a low grade or high grade impression of the colposcopy as such, that needs to be mentioned. What is the type of transformation zone, whether it is type 1, type 2 or type 3? What is type 1, what is type 2 and what is type 3, we will see subsequently. And a site of biopsy, if the biopsy is taken, what is the site of biopsy, that one needs to mention. So these are the specific things one should record in the colposcopy clinic, right from the indication for referral, the HRHP, because when the patient comes for colposcopy, that means HRHPV is done and the cytology is there. Then what is the report of that? Because with this particular background, further management will depend. Okay. Now, invasive disease. When to consider, whenever you suspect that there is an invasive disease, you will go for excision. Okay. And in that particular case, sometimes this punch biopsies may be unreliable. Okay. So we do punch biopsy also, but in such cases where there is a suspicion of invasive disease, go for excision. Okay. Most of the, when it is indicated, most of ectocervix, which is replaced by high grade abnormality. Okay. So when most of ectocervix, which is replaced by high grade abnormality, will go for excision. Excision means leads or leap. Okay. If you have a low grade change but high grade dyskaryosis or severe cytology, that means your colposcopic impression is low grade but the cytology is high grade or severe cytology, that is an indication for excision. Okay. If your lesion is extending to the endocervical canal, that is also indication for excision. Then cytology is suggestive of invasive disease or glandular neoplasia, go for excision. Punch biopsies may be unreliable. Reasons for not performing must be recorded. Okay. Excisional specimens should be single piece in more than 80% cases to allow accurate margin assessment and maintain histological quality. Fragmentation impairs diagnosis and indicates suboptimal technique. So when you think about the excision means whatever you see the lesion, you will remove it completely. Okay. And that should be taken in single piece, because in that particular case, when it will be sent for histopathology, you need to assess the margin. So accurate margin assessment is possible and that will maintain the histological quality. Fragmentation will impair the diagnosis and indicate suboptimal technique. So when you do the colposcopy, your colposcopic impression, your previous reports of cytology, they are going to be very, very important. Okay. So accuracy of colposcopic diagnosis, that is the positive predictive value. That means colposcopy, you are mentioning it is a high grade, whether it is high or high grade or low. Then suppose your high grade cytology is there and you are doing the colposcopy and taking the biopsy. Okay, in that particular case, positive predictive value of getting CIN2 plus is more than 75%. Okay, that means your background cytology is going to be very, very important. But if there is only persistent HRHPV positive and the cytology is negative, we have seen in these cases at 24 months, you are going to refer these patients for colposcopy. Okay. And having the histologically abnormal finding in these cases is less. So only more than 35%, around 35% of cases, you will find the positive this colposcopic findings on which is confirmed by the histology. That is what is the positive predictive value. Proportion of high grade colposcopic impression confirmed by histology. Okay, so your impression is a high grade and which is confirmed by the histology is more if your cytology is high grade. Okay, if your cytology is negative, there is a less positive predictive value for having the histologically confirmed report. Okay. Now, colposcopically directed punch biopsy should be performed when cytology is high grade or atypical transformation zone is visible. It is not mandatory if HRHPV is positive and negative or low grade cytology and normal colposcopy. So, if your colposcopy is normal, cytology is low grade, only HRHPV is positive, in that particular case, punch biopsy not mandatory. The adequacy is that you should have a more than 90% suitable for histology. So whatever the biopsy you will take, that should be adequate enough to report during the histopathology. If it is inadequate, then you will repeat the biopsy if the lesion persists. Okay. Now, what is the treatment of CIN? Okay. So treatment of CIN will based on the cytology, colposcopy, and the biopsy correlation. Okay. All these three things are important. Okay. They must be done in equipped staff clinics and recorded in the database. Now, from here onwards, the questions are going to be very, or the information is going to be very important from your part 2 point of view. They will ask you about the next step, and there are various flow charts. Okay. Now, what is the surgical and local ablative technique which is used? You can have either ablation, cryotherapy, and excision. Okay. Cryotherapy is possible only when you have a low grade CIN and you have to use double freeze thaw freeze okay technique. Then ablation, that is laser diathermy, is possible. For that you need to have entire TZ which is seen, transformation zone which is seen. There should not be any glandular or invasive suspicion. There should not be any discrepancy, and there should not be any prior treatment. This is avoided in more than 50 years. So laser diathermy, avoid more than 50 years. If it is a low grade CIN, the cryocattery is used. If the ablation technique is to be used, in that particular, the entire TZ should be seen. There should be no suspicion of invasion or the glandular abnormality. There should not be any discrepancy. There should not be any prior treatment. Otherwise, go for excision. This is preferred when diagnosis is uncertain or lesion is extensive. 80% specimen should be single and not fragmented. This is actually a quality control criteria. When you take out the specimen, in 80% of cases, it should be a single specimen because histological quality will be maintained. And that is what is going to be very important. And when you are excising, that is best because you need to have a histological quality also. Okay. So if all these options are given, just select which one is best in that scenario. Excision will be best because it will maintain the histological quality. For low grade CIN, you may select the cryocattery also. If the age is more than 50 years, don't select the ablation or the laser or diathermy. Okay. Now, this is what is we have just seen previously. What is the type of transformation zone? Then how much, when you are excising, how much to excise? This will depend upon the transformation zone type. You have three types of transformation zone: type 1, type 2, and type 3. Okay. If it is a type 1, that means completely ectocervical lesion. Okay. Your lesion is completely ectocervical. Depth of excision will be around 7 millimeters. So aim should be less than 10 millimeter in reproductive age. So in type 1, where your cervical lesion is restricted to the ectocervix only around 7 millimeter or less than 10 millimeter excision is more than depth of excision is sufficient. Well, in type 2, how much excision you require? 10 to 15 millimeter, and here there is endocervical involvement also. So you have the involvement in the endocervix also. In type 3, the excision is more, 15 to 25 millimeter, and deep endocervical canal involvement is there. Okay, so this is the type 3 type of transformation zone where the lesion is extending deeply into the endocervical canal, and you require more excision. And these are the patients who may land up with a mid-trimester abortions or preterm in the subsequent pregnancy if they conceive. Okay, So this particular is depth of excision is going to be very, very important. Okay, see and treat policy. Okay, now high grade cytology is there. Then you will offer them the treatment in the first visit, and more than 90% will show CIN 2, 3 or CGIN on the histology. While you just have HRHPV positive, but the cytology is negative or low grade, you may not offer the treatment in the first visit, and always avoid the over treatment also. That is what is the role of colposcopic cleaning. You have see and treat policy, you have to treat appropriately, and you have to avoid over treatment also. Okay, and that is why the first slide, what are the things which you will take into account? What is the HRHPV result? What is the cytology? What is the grade of the cytology? Everything you have to take into account, and then you have to decide the excision. The excision will also depend upon the involvement of the lesion, whether it is involving into the ectocervix, whether there is an extension into the endocervical canal, or whether there is a deep endocervical involvement, and accordingly you will select the depth of excision. Is it clear? Is it clear, doctor? Okay. Now coming to the
Yes, sir.
timing of treatment. Timing of treatment. Okay. High grade CI, definitive treatment within 4 weeks of the biopsy report. Okay, so you have done the punch biopsy and followed by there is a treatment. So if there is a high grade CIN, you have to offer the definitive treatment within 4 weeks of the biopsy report, and more than 90% should be treated within 8 weeks. Okay, repeat excision policy. Okay, so repeat excision uh, after 50 years of age, repeat excision to achieve clear margins. But if she is less than 50 years and there is no glandular or invasive disease, then you can keep her for observation. No routine repeat excision is advised. So this can also be a question that there is a high grade CIN, excision treatment is done, but the margins are involved. In that particular case, you see the age of the patient, you see the type of abnormality, whether there is a glandular abnormality or not. Okay, if she is young, less than 50 years, there is no glandular abnormality, then she can be kept for observation and there is no routine repeat excision indicated. But if she is more than 50 years, or in these parameters there is a gland, then repeat excision then the repeat excision is required. If she is more than 50 years, repeat excision is required. Okay, if she is less than 50 years, then observation is sufficient. Okay, anesthesia will be local anesthesia more than 85% and target is 90%. General anesthesia will be gone only when necessary. Okay? Now management of glandular abnormalities. Okay, now cytology reporting and referral. Glandular neoplasia of endocervical type, we have already seen there is a 2-week pathway. Urgent gynecological referral, 2-week pathway, 93% target. Okay, audit. There is punch biopsy is not recommended. Diagnosis via excisional biopsy, including the endocervical. Whenever there is a CGIN, better to go for excision. Okay. Then management of CGIN, cervical glandular intraepithelial neoplasia. Okay. If there is a suspected CGIN, what you do? Cylindrical excision, including the transformation zone, and 10 to 25 millimeter of endocervix, depending on the age and visibility. Okay, so around this cylindrical excision will be required, and you have to include the transformation. Now, what if you have completely excised? What is the follow-up of CGIN? You will do the test of cure at 6 months, 18 months. If both are negative, she will come for routine recall. The routine 3 years recall, not routine recall. It is a 3-year recall. Okay, this also we have seen. If there is incomplete excision, repeat excision, or if it is decline, HRHPV at 6 months, 12 months, and annual for 9 years. Okay, and if there is a recurrent or complex cases, they need discussion in the MDT. This difference we have already seen: complete excision of CGIN and incomplete excision. Okay, so I will not go into the detail again. Then if you have got a report of the biopsy as a smile, that is stratified mucin producing intraepithelial lesion, this treatment is managed as same as CGIN, which we have already seen. So even if your report is smile, that is stratified mucin producing intraepithelial lesion, it is managed same as CGIN. Okay. Now, hysterectomy as an option. Okay, hysterectomy can be considered if there is no desire for the fertility. Positive margins after adequate excision, you have excised, but still the margins are positive. Further high-grade cytology is there. incomplete follow-up, stenosis, or other indications, and invasion is excluded. If there is no invasion, fertility is not desired, but there is a positive margin, and the possibility of the follow-up is less. In that particular case, hysterectomy may be considered. Okay, follow-up after colposcopy. Now, you have done the CIN treatment or early cervical cancer treatment, and what is the further follow-up? All treated individuals will be followed up at 6 months for test of cure. Okay, risk of recurrence is 2 to 5 times higher. Okay, and compliance is critical. So there is a high risk of recurrence, and that is why the compliance is the most important thing. Okay, follow up after CIN treatment, HPV test of cure pathway. Okay, HRHPV is negative, she'll be recalled in 3 years. Okay, HRHPV is positive, she'll be referred for colposcopy. If HRHPV is unavailable, repeat in 3 months, and at age more than 65 years, continue the follow-up until criteria are met. Okay, this also we have seen. Okay, here in this particular case, in TOC pathway, it does not end at 65. She requires, she needs to be in the follow-up. Okay. Now, early cervical cancer and post-hysterectomy follow-up. Okay, in stage 1A1, that is microinvasive, okay, CS cervix, which is treated conservatively. What is the follow-up? You will do test of cure at 6 months and 12 months and annual for 9 years. Okay, so here stage 1A1, which is treated conservatively, test of cure at 6 months and 12 months, and further annual follow-up for 9 years is required. Stage 1A2 and 1B1, these are actually not for treatment, so the follow-up will be for oncologist protocol. Whatever will be the follow-up advised by the oncologist, that will be followed and seized from the screening. Okay, post hysterectomy with CIN. Now this we will go into the details in the subsequent slide. Okay, they require wall samples at 6 months, 12 months, 24 months, depending upon the CIN grade, and it is to be continued to 65 years or 10 years post surgery. And most of the time the question is asked from this particular part. Okay, sometimes here also they can ask you stage 1A1 treated, so it requires TOC at 6 months, 12 months, and annual follow-up for 9 years. Okay, this and this they can ask you. Okay, this post hysterectomy, just see carefully, there are various options which are available. Now you have done the hysterectomy, okay, and there is no CIN in the specimen. Okay, so the hysterectomy is done, she was on routine recall, there is no CIN, there is no further management or the no further wall sample is required. So the hysterectomy is done, the hysterectomy was not showing any CIN, and previous all reports smear were normal, so wall sampling is not required. Okay, now you have done the hysterectomy, but the specimen shows a CIN which is completely excised. So there was a CIN, but it is excised completely. Then what you will do? You will repeat the sample, vault sample at 6 months. If it is negative, then she will be discharged. Okay, so it depends upon the histopathology. You have done the hysterectomy, and there is a CIN in the histopathology, but it is completely excised. Then obviously test of cure at the end of 6 months. If the test of cure is negative, she will not require further follow-up, she will be discharged. Okay, so the option will be discharge from the follow-up. Okay, but you have a CIN which is completely excised, you have done the TOC, and your test of cure becomes positive. Now she becomes HRHPV positive at the end of 6 months. Obviously she will be referred for colposcopy, and if there is no VIN, that is vaginal intraepithelial neoplasia, then she will be discharged. Even if the HRHPV is positive, okay, the cytology is negative, she will be referred for colposcopy. But if there is no VAIN, then she will be discharged. So there is a difference between these two. So in first case, there was a CIN which was completely excised, only one test of cure was required. Okay, if it is negative, she will be discharged. Here, CIN which is completely excised, but HRHPV during the TOC is positive. Okay, cytology is negative, she will be referred for colposcopy, but she will be discharged if there is no vaginal intraepithelial neoplasia. Okay, now you have a third category in which there is a CIN into the histopathology, but it is incompletely excised or uncertain margin, and this CIN is a CIN 1. Okay, then you require ward sample at 6 months, 12 months and 24 months. Okay, but she will require a continuous follow-up till 65 years or 10 years post-surgery. Okay, now there is a difference. First was a CIN which was completely excised with HRHPV is negative. Another scenario, the CIN was completely excised, but HRHPV TOC was positive. Then the management you should know. Then third is a CIN which was incomplete excised, but the CIN was a CIN1 which has got a low chance of recurrence, low chance of further malignancy or progression. In that particular case, you require ward sample at 6 months, 12 months and 24 months, but the follow-up will continue up till 65 years or 10 years post-surgery. Now, the next scenario, you have CIN which is incomplete excised or uncertain margin, but it is a CIN 2 or 3 that has got a high chance of recurrence. You will take the sample at 6 months, 12 months, and then annually for 9 years. Okay, so here at 6 months, 12 months, 24 months, but after that she will go for routine recall. Here it is 6 months, 12 months, and then she will go for annual recall. Okay, for 9 years, and this follow-up will continue till 65 years or 10 years post surgery. Okay, even if she crosses 65, the 10 years follow-up will continue. Okay, that is why in these particular cases what we have seen, the follow-up does not end because they are for a spatial follow-up. Okay, are you getting it, this, Dr. Sinchana?
Yes, sir. I follow.
Okay, various scenarios you have understood. Hysterectomy scenarios.
Yes,
Okay,
sir.
complete excision, incomplete excision, incomplete excision. What is the finding? CIN, CIN 2 or 3. Okay, here 6 months, 12 months, 24 months. Here 6 months, 12 months, and then annual follow-up. Here after that, after 24 becomes routine recall. Okay, so same thing is there. Now for CIN 2, is there a conservative management? Okay, that means you have done the this colposcopy, and colposcopy shows CIN2. In that particular case, you whether to go ahead with the excision or not. Okay, it is always better to go for excision, but there is a role of conservative management. If you have done the colposcopy and you have excluded the CIN3 or invasion, the patient is coming for follow-up every 6 monthly. Your invasion lesion is less than 2 quadrants. The MDT review is done. Okay, CIN2 is confirmed histopathologically. These patients can be kept for observation. If it is not resolved by 24 months, then you go for treatment. Okay, so you have done a colposcopy and you find CIN2, and generally we prefer excision. Okay, CIN2, CIN3. But which patients you can give conservative management? You have done the colposcopy, which was adequate. There is no CIN3 or invasion. Patient is regular coming for follow-up for 6 months. The lesion is less than 2 quadrants. The MDT review, it is discussed, and CIN2 is histopathologically confirmed. Those patients you can keep for follow-up for 24 months. But if it is not getting resolved, then you have to treat it. Okay, if CIN is completely excised but 6 months test of cure shows HRHP positive, cytology negative, she goes for colposcopy. If colposcopy is normal and no VIN is present, she is discharged from the routine screening. This is for the post-hysterectomy follow-up. Okay, CIN which is completely excised. Okay, this is what is for the post-hysterectomy. Now, ward sampling and follow-up after hysterectomy, same what we have seen. If there is a CIN1, 3 years ward test. Okay, 6 months, 12 months, 24 months, then routine long-term follow-up. Here 6 months and 12 months, and then annual follow-up for 9 years. This is more intensive. This one is more intensive. For CIN1, not that intensive. Okay, duration, both require long-term follow-up, but CIN2 has got a structured annual follow-up for nearly decade. Okay, reason is that CIN1 low malignant potential, fewer tests after initial monitoring. CIN2-3 has got a higher risk of VIN and vaginal carcinoma. Tighter surveillance is required. After hysterectomy with incomplete or uncertain excision, CIN1 samples will be taken 6 months, 12 months, and 24 months. After that, she will be for routine recall till 65 years or 10 years post-surgery, while it is 6 months, 12 months, and annual for 9 years. Okay, high-grade CIN needs prolonged annual follow-up due to high recurrence risk. Okay, so same thing. Now let's see. So you had HRHPV positive, then the patient and the cytology showing some abnormality. That may be low grade or high grade, and you are sending the patient for colposcopic examination, then colposcopy may be adequate or may be inadequate. So you have done the colposcopy, but the colposcopy is inadequate. In that particular case, you have to see the background cytology and decide the further management. Okay. Now your index HRHPV is positive, but the cytology is low grade. Then you will repeat the colposcopy in 12 months, and at the end of 12 months, okay, repeat colposcopy inadequate. If at the end of 12 months, if the colposcopy is inadequate, then you will go for leads. Okay. So this is also scenario they can give you, that HRHPV was positive, cytology was either low grade or high grade, they will mention. Then definitely the patient requires colposcopy. The colposcopy is done, but then what they will give, you concentrate whether it was adequate colposcopy or whether it was inadequate. If it was inadequate, go back and see the cytology report. Okay. If the cytology is low grade, then repeat the colposcopy in 12 months. Okay. But at the end of 12 months also, if it is inadequate, then go for leads. Same like what we have seen HRHPV. Okay. HRHPV at 24 months is going to be here for inadequate colposcopy at 12 months. Okay. Here you will go for excision. There you will go for colposcopy. Are you able to correlate this, Dr. Shinchana?
Yes, sir.
Okay. So your patient is for colposcopy, it is inadequate, but the cytology is low grade, so repeats colposcopy in 12 months. At 12 months again inadequate, then go for leads. Okay. Now, if it is an inadequate colposcopy, but there is a high grade cytology, go for excision. Okay. This we have seen when to excise. Okay. You will always high grade, you go for excision, that is you perform the leads. Now, you have performed the colposcopy, but the colposcopy is adequate. Okay. Now, your colposcopy is adequate. You have taken the biopsy, and biopsy there is no CIN. Okay, or biopsy has not been taken because there is no colposcopic impression of CIN, and your index HRHP is positive. Cytology is low grade. She will come for recall in 36 months. Okay, she will come for recall in 36 months. Okay, then you have done the colposcopy. Colposcopy is adequate. Okay, but here your high grade HRHP is positive and the cytology is high grade. This case you will discuss in the MDT within 2 months. Okay, this case requires MDT discussion in 2 months. Okay, you have performed the colposcopy, you have performed the biopsy. Okay, the biopsy is CIN 1 plus, means 2 or 3, or colposcopic impression of CIN. Okay, these patients are managed according to the abnormal colposcopy. So you have done the colposcopy. Colposcopy is adequate, and there are abnormalities that you will manage as per the abnormal colposcopy. But the colposcopy is normal. In that particular case, you will see the whether the this is low grade or high grade. If it is low grade, then you will call her for in 36 months. But if it is a high grade, in that particular case, this requires discussion with at MDT in 2 months. Okay, so this is also a question which has been asked many times. Okay, this has also been asked. Okay, so colposcopy is adequate, and there is no CIN, but your cytology is abnormal. That case requires, because your colposcopy is normal. Okay, why the colposcopy is normal? That is a question you want to discuss. When the cytology is abnormal, you expect something to be seen in the colposcopy also. When there is such discrepancy, you have to discuss this case in the MDT. But if the colposcopy is also abnormal, then definitely you will manage this as a abnormal colposcopy in the subsequent flowchart. Okay. Now let us see. Here this flowchart is about abnormal colposcopic finding. Okay, you have done the colposcopy. Colposcopy is abnormal. This abnormality may be CIN1, CIN2, and CG. It may be CGIN. CIN. It may be CIN2 or 3. Okay, so abnormal colposcopy can be CIN1, CIN2, 3, or CGI. Okay, out of which CGIN will definitely have a strict protocol. Then let us see about CIN2 and 3. Okay, CIN1 is mild, so we'll take in the after this CIN2. So you have done the colposcopy. Colposcopy shows either CIN2 or CIN3. Then what we are going to do? we are going to treat by excision. Okay, then you will call them for test of cure. If the test of cure is negative, she will be recall in 36 months. Remember, this is not a recall routine, this is recall in 36 months. What is the difference between the 36-month recall and routine recall, doctor?
The routine recall is in 12 months. This is in 36 months.
No, routine recall is not 12 months, doctor. Routine recall is her routine recall. If she is
Okay, okay.
between
Yes.
25 to 49, her routine recall is 3
3 years.
yearly.
3 years.
Okay. And if it is between 50 to 65, her
It is
recall is 5
5 years.
years. But
5 years.
even if it is,
Yes.
she is say 52 years, here she will not come after 5 years. She will come after 36 years because she is under this. And that is what is the difference in the option in EMQ. Okay, whether it is
Yes.
a routine recall or whether it is a recall in 36 months. Okay, so please remember this particular flow chart, because CIN2, CIN3, you will require colposcopic treatment, you will treat them, you will call them for TOC, then the TOC is negative, they will come for, that means you have taken care of the pathology. Okay, and the HRHPV is also negative, that means she has become relatively low risk, so you will keep her for follow, but the follow-up will be 36 months. Okay, now you have treated the CIN2, CIN3. Okay, then you will call her for TOC. The TOC has become positive, the cytology is negative, inadequate, but HRHPV is positive. Definitely you refer these patients for colposcopy again. Okay, this flowchart is relatively simple. I don't think any problem there should be with this. Is it clear? CIN2, 3,
Yes.
okay. Now let's say about
Yes, sir.
CIN1. Okay, CIN1 is a mild this pathological issue. So colposcopy is abnormal. You have taken the biopsy and you got a CIN1 as a report, or a colposcopic impression as a CIN1. Then you will call these patients in 12 months, see the HRHPV. If the HRHPV is negative, you will recall in 36 months. Here always recall in 36 months. Okay. Now here your HRHPV is positive, but it is only CIN1. Okay. Then what you do, you again recall in 12 months. These patients will be recalled again in 12 months because it is a CIN1. Okay. HRHPV is positive. Then you call these patients in 12 months. The cytology is negative. In 12 months, again you see whether HRHPV is negative or not. If it is negative, she will be recalling 36 months. Colposcopy, remember, recall is always in 36 months. Okay. Here, CIN1 patients recall in 12 months. Okay. This is the final recall. So CIN1, you don't treat, go for excision. Okay. You keep them for follow-up. You called her for 12 months again. HRHPV is done. If it is negative, she will be recalling 36 months. But at 12 months, if the HRHPV is positive, then look for cytology. If it is negative, she will be for 12 months follow. Okay. If it is 12 months negative, then she will be recalling 36. This is the final recall. Okay. Because HRHPV has become negative. If HRHPV is positive, cytology is negative, this is the only case where you are giving her, in spite of HRHPV positive, you are giving her follow-up at 36 months. Okay. And if the cytology is abnormal, she will be referred for colposcopy. Okay. So this particular CIN1 also you should remember, because in this CIN1, you are not going to excise. You will repeat HRHPV in 12 months. Okay. If HRHPV is negative, she will be for follow-up at 36 months. HRHPV is positive, the cytology is negative, again recall in 12 months. If it is negative, recall in 36 months. Now, your HRHPV is positive here also at the end of 24. Then also she will be given recall because you have done her colposcopy 2 times and the colposcopy is normal. Okay, she is only HRHPV, and this is the only case where there is a, in spite of HRHPV positive, you are giving the recall in 36 months. Okay, so in CIN1 at the end of 24 months, if your colposcopy is normal but HRHPV is positive, then also you have a recall in 36 months provided the cytology is normal. Okay, if the cytology is abnormal, definitely she goes to the colposcopy. Is it clear? CIN1.
Yes, sir.
So CIN1 in general 12 months follow-up till HRHPV becomes negative, but only at the end of 24 months she will still be for recall in 36
36
months.
months.
Okay, provided the cytology is negative. Okay, I'm going into too much of detail, repeating it again and again, just so that you will not have any confusion in selecting the option. Okay. Now, third
Yes,
is a
sir.
CGIN. Okay. Now, CGIN is definitely we are going to worry about these patients. Definitely, it requires excisional treatment. Okay. They will be called for TOC. And the TOC for CGIN is how many TOCs will be required? Two TOCs.
Two
One at
TOCs.
6, yeah, one at 6 months, another at 18 months. That is 6
18
months,
months.
yeah, 12 months after this. Okay, and 6 months, sorry, 18 months after the excision and 12 months after the first use. Okay. Now, if both are negative, that is fine. Then she comes in a routine recall. Okay, so first 6 months, then another at 12 months, that is 18 months. Okay, then both negative, no problem, she will be coming for recalling 36 months. Okay, if either of these is positive, either 6 months or 18 months is positive, then what is the her management? Okay, so the first TOC at 6 months and second TOC at 18 months. The management is almost same in both cases. Remember, okay. See, HRHPV is positive at or TOC is positive at 6 months. Cytology is negative or inadequate. She will be referred for colposcopy. If colposcopy is normal, she will be recalled in 12 months again. Okay. Here, is normal, first TOC is, but second is positive. Okay, HRHP is positive. Then again cytology is negative and or inadequate. Then she will be referred for colposcopy. And if the colposcopy is normal, then recall in 12 months. Okay, so these patients will be 12 months recall. HRHPV is positive, cytology is negative. Keep 12 months follow-up, colposcopic follow-up. Okay, these patients will be for colposcopic follow-up. Then you have at 6 months or 12 months, HRHPV is positive, but the cytology is abnormal. You will be referring these patients for colposcopy. If normal colposcopy and or no re-excision, there is a complete 10 years follow-up. Even at 18 months, if the cytology is abnormal, these patients will also require 10 years follow-up. Okay. So both these places, if the cytology is abnormal, 10 years follow-up is required. While if cytology is negative, keep them for annual follow-up. Okay, 12 months follow, recall in 12 months, recall in 12 months. Okay, so that is what is the colposcopy examination. Okay, then key performance standards, not very important from examination point of view. Positive predictive value for high grade cytology referral is more than 75%. Positive predictive value for other referral, that is only HRHP cytology negative, it is 35%. Adequate biopsies for histology should be more than 90%. Single piece excision should be more than 80%. Treated within 4 weeks should be more than 90%. Treated under local anesthesia should be more than 80%. Target is around 9%. And histological treatment failure should be less than 5%. That means recurrence. Okay, you have treated these patients, but you have called them for further follow-up, and during that there is a recurrence, that should be 5%. This is what is the quality assurance of your colposcopic treatment.